Hi and welcome. I'm Joanne MacInnis. I'm a registered nurse. I am the founder and owner of Aberdeen Home Care in Danvers. And today it's important for us to talk about it's not if, but when you end up going to the emergency room. When an emergency room visit is necessary, how will you navigate it? Most people really don't understand the function of the emergency room. They think it's the hospital. And so all things will be happening there. I'll figure out what's going on, I'll get treatment, I'll get better, and I'll go home. Maybe that's the overall expectation. But it's very important, especially now in the time of COVID, to understand what might be happening in the emergency room, what you need to know, how you can be prepared, and your healthcare proxy, loved one, next of kin, family member, whoever it is that you rely on in a medical situation or emergency, it's important that they have access to this information too. So what are the things that bring us to the emergency room? Generally, it's one of two things. Either it's a trauma, which means you have a fall, you cut yourself, you burn yourself, you fall and hit your head, you're in a car accident, you fall off a ladder. Something like that is designated as a traumatic injury, traumatic event. That will bring you to the emergency room. The second thing is a sickness. Whether you have new symptoms that you've never had before, maybe you've never had a cardiac issue and you have chest pain, shortness of breath, maybe there's a bleeding situation, whatever it is that might be illness related rather than trauma related, that could also get you to the emergency room. If you have a condition that worsens, if you're asthmatic, for instance, if you have a seizure disorder, and something sort of presents itself in worsening your condition, that will also be a catalyst to get you to the emergency room. So it depends why we're going. That's one important feature to keep in mind when we're navigating an emergency room visit. What information about you is available? That's going to be issue number 2. And when you see this presentation, by the way, you will have a wonderful handout which will follow the presentation, and you can take notes on whatever we're talking about so to keep it fresh in your mind. So what brings you to the emergency room? A traumatic event or worsening or new illness. And then what information about you is available. This is critically important. If the emergency responders who come and pick you up in an ambulance or your loved one that gets you in the car to take you to the hospital does not have information about your medical situation, then you become a John or a Jane Doe at the emergency room. Certainly they have your name and all of that, but if they don't have your information, your treatment gets delayed. If the emergency department has access to your medical information, your diagnoses, your doctor's name, your medications, your allergies, and so on, then treatment becomes much more readily available for you the minute you get in the door. And why that's important is that in some situations, every second counts. So what I am proposing and have for 20 years that I've been in my practice at Aberdeen Home Care is that a medical emergency kit is in everyone's best interest. This is the kit. It's a vinyl packet that we give to all of our clients at Aberdeen. You can use a brown envelope. You can use a regular legal size envelope with your name on it, as long as it's readily available in your home and everyone knows where it is. My packet comes with a nice magnet. It sticks right on the refrigerator. The reason that this is important, the location, is that in emergency response and public health, the refrigerator is always the designated location for these very important documents. That's the first place that someone will go to look for your information if there's no one there to direct them. So what are we going to put inside this packet? Well, we have a medical information sheet that we put in ours, and I'll give you instructions how to download this very document if you'd like to use it for yourself at the end of the presentation. It's right on our website. So this is your emergency medical information. It's got everything on here about who's who you are, who is your healthcare proxy, how do we reach them, who is your primary care physician. You probably have specialty physicians. Who are they? And then, what considerations do you have? Do you have a pacemaker? Do you have high blood pressure? And then on the back, we have a medication list. This is critically important, and it saves very valuable time for the emergency responders who are helping you to get to the hospital, which is where you need to be. So your information sheet, that's going to be centrally important inside of your packet. The second thing that's very important and essential is your Massachusetts healthcare proxy. We do not have in Massachusetts automatic spousal authority for health matters of healthcare proxy. So if you're 80 years old and you've been married for 60 years, you are not guaranteed to be the healthcare proxy for your spouse. So having this document is essentially important. So you name who is your first selected agent and your second selected agent. A copy of this document, very important to have in your file. Now, a lot of these documents might have been done for you with an estate planning attorney or an elder law attorney, getting your documents in order, which is obviously so much more than your will and power of attorney. That's great because it helps with your assets and your property. I'm much more concerned about you. And so having your healthcare proxy designation available, critically important, as is this hot pink document. This is called the MOLST, M-O-L-S-T. And this stands for Medical Orders of Life-Sustaining Treatment. You may have been familiar with the term DNR. That means do not resuscitate. That is something that might be advised if you are of a certain age and have a medical condition or conditions that may eliminate you from being a really good candidate for resuscitation. If you're end-stage cardiac or lung disease, pulmonary disease, if your loved one has end-stage dementia or Alzheimer's disease, it may not be in their best interest to try and undergo a resuscitative effort, which is not always successful in the best of times. So this document discusses 4 main things that you really need to consider with your family, maybe with your physician. This is a doctor's order, and even if you fill this out at home, which you can do, your physician will need to sign this. Physician, physician's assistant, or nurse practitioner will need to sign this document to make it legally binding, and you can change this at any time. Once you do it, you can change it in a week or 2 weeks, but that gets confusing. So it's good to really consider what you want to be stated in this document, and then distribute this to everyone who's sort of in your team. Think about who's in your team. You have your healthcare proxy agent 1 and 2. If you have 10 children, probably at least 8 out of the 10 of them are going to be in your team. You have a financial advisor. You have a physician. You may have several physicians. Your attorney may be part of that team. In many cases, Aberdeen Home Care serves as a very important part of that team for someone who may be exhibiting a life-limiting illness or a deteriorating condition, people that we're taking care of. So the hot pink form is going to say how you feel about dialysis, intravenous, hydration, tube feeding, and resuscitative effort. This can be downloaded. You can also get it from our website, but this can be downloaded off the Mass Department of Public Health website. And don't worry about taking notes on all of this. All these graphics will appear for you magically at the end of the program, and they will be sites that you can go and get these very important documents. So once you have your MOLST, your hot pink document done with your wishes, you have your healthcare proxy done, which names your agent number 1 and agent number 2. Let me explain a little bit about what that means. When you sign the proxy document, it does not transfer power to that person immediately like a power of attorney does. It says that in the event you are unable to make your own medical decisions, and that has to be decided by a physician, that the proxy becomes what's called invoked. And so the proxy becomes activated, but it's very important that you have this filled out prior to an event like that. Because if you are without mental clarity or what's called capacity, you're not allowed to fill this document out, just like you're not allowed to fill out a power of attorney document. Your medical information, incredibly important. All of those are going to go into your packet, the packet of your choosing. Whether you do a homemade packet, if you're on service with Aberdeen, you'll have this nice vinyl packet, but something that puts everything together. If you've had an appointment with an elder law attorney, estate planning attorney, and these documents have been done for you, that's great. But where are they when you need them? They can't be in your file cabinet at home or your office or at your attorney's office. They need to be readily available at all times. Now, many of you, like me, are out and about. And so what happens if you are at a restaurant and something happens and you need to be taken by ambulance to be evaluated at the emergency department? Well, you need a wallet card. And on this wallet card is a condensed version of everything that's on the master emergency information sheet in your packet. So on the front we have your diagnoses, your emergency contacts. On the back we have your medications. And so this goes right behind your driver's license. And if you should ever need emergency help, that's where all first responders are trained to look, behind the driver's license. And this could be the difference between having a great outcome and having a not so great outcome. So very important to have a wallet card. You don't have to have a fancy pre-printed card like I do. You can take a little 3x5 index card, trim it so that it fits inside your wallet, and write down your information there. So by the time you get to the emergency department, if you have been picked up by emergency responders and ambulance 911, they're radioing into the emergency room where you're going. We have an 80-year-old female who has a history of open heart surgery. She takes a blood thinner. She takes several cardiac medications. She was found to be dizzy, with low blood pressure, with chest pain. Whatever the story is, it's getting called into the emergency department ahead of your arrival, so that when you get there, you are not a mystery patient on a stretcher who has become unresponsive at a restaurant. You are Mary Smith, and we know about your medical situation. We know who your doctor is. We know who your healthcare proxy is. So all these things are in motion rather than being in the collection stage of the identity. Who are you and what are your issues? Very important. Okay, so what happens once you get to the emergency room? You're wheeled in, or you're dropped off, and you're finally being seen. What are your expectations? So the first thing that's going to happen in the emergency room after you're identified and we have your medical history, which you've provided, well done you, is going to be diagnosis. What has brought you in? And that may involve many medical tests. Certainly your vital signs will be monitored. You probably have some blood work done. You may have some diagnostic x-rays, CAT scan, MRI, something like that. You may see a specialist. If you fall and you have hip pain, you'll probably be seen by an orthopedist in the emergency room to evaluate, is there something broken? So diagnosis, that's going to be the very first part of what happens once your identity is clear coming into the emergency room. Once the diagnostic process is finished, will become stabilization. If you come in with a big gash or a big burn, we're going to diagnose that as a third-degree burn. That third-degree burn needs treatment, and what treatment will that be? So there's your stabilization period. So diagnosis and stabilization. The next thing is treatment. So if we've stopped the bleeding on your burn, or we've given you medication for your chest pain and you've become stabilized, then it becomes treatment. How do we treat what the symptoms that we see right in front of us, and maybe there's something underlying that needs to be treated? Let's take stroke for an example. So your face is drooping, or you're unable to speak, and this probably rings true for some of you who have been through this with loved ones. And so it seems as though a stroke has happened, and you're in the emergency room, and you're being evaluated by the team, and they're saying, yes, it looks to us as if a stroke has happened. We haven't done an MRI, we don't have definitive evidence, but based on symptoms, that's what it looks like. So what do we need to do right now to stabilize you? There are certain medications that are given with some strokes that are appropriate, but then we need to look at further treatment. You probably need to be admitted to the hospital to see if the stroke has ended or if it's going to be continuing, until we know what the damage or residual is, which means if you're left with one-sided paralysis or confusion or inability to swallow, speak, that kind of thing. What is the damage that's been done by this stroke? And then we're talking about discharge from the emergency room. Has something very small happened? Have you had a dizzy spell? And it was determined that your blood pressure was too low. And so the emergency room physician has decided we're going to back off a little on your blood pressure medication. And we're going to make sure you see your physician tomorrow to get checked out again, maybe with some home instructions to get a blood pressure monitor on the way home so that we can check your blood pressure at home. That would be a very simple kind of black and white example of what an emergency room visit does and does not do. And so you come in with low blood pressure, dizzy, maybe you've had a fall and you've been checked out. There's been no damage because of the fall. Your blood pressure remains low. So again, the emergency room physician reduces your blood pressure medication and makes a short-term plan for you to be discharged from the emergency room back home, but with a plan to get a blood pressure cuff, monitor your blood pressure, and see your physician the next day. So in that situation, you've come to the emergency room, you've been identified, you've been diagnosed, you've been stabilized, you've been treated, and now it's appropriate to discharge you home with follow-up care. So what happens if your trajectory is different than that and instead of being discharged, you're admitted to the hospital? So we're not sure what's wrong. You're going to need to have more diagnostic tests than can be performed from the emergency room. You're medically not stable, and so the best decision is to admit you to the hospital where you can be monitored and cared for, and where the diagnostic testing can continue until we are very solid in what the diagnosis and the treatment should be for you. So that's really what you're expecting when you get to the emergency room. It's not a place you'll stay. It's a landing ground. That's what your entry portal into the hospital, and we decide, is your situation managed well at home? Are there people that can take care of you? Is it safe to let you leave the hospital? Yes or no, and then you're admitted into the hospital for more diagnosis. Sometimes advocacy is really important when you are in that situation. We've all been in a medical emergency. It might not have been ours, but it's been someone. A child falls out of a tree. A parent, something happens to a parent. We've all been in a situation where we're the advocate for the person who has experienced the emergency. Our ability to advocate sometimes, again, is the difference between a great outcome and a not great outcome. So this type of instruction really arms you and prepares you for your role as an advocate in the emergency room. Now you know how to be prepared with your information. You understand what's going to happen when you get to the emergency room. What are the sort of check-off boxes that happen from the emergency room staff's position about what's next with you. Sometimes you're waiting and you're wondering, gee, what's going on? I haven't seen anybody in a little while, because maybe your test is being evaluated, your CAT scan or your blood work, and they're having a conference to discuss what's going on. Oh, we've noticed something very abnormal in your blood work. We need to pull somebody else in, a hematologist, for instance, that's a specialist in blood disorders, to take a look at what your result is before they come in and talk to you. Because it's hard as a nurse, I'll tell you, to go in and say, oh, your results were very abnormal. Great. It's much nicer to walk in and say, we did notice something abnormal about your blood work, and here's a hematologist, a specialist in blood disorders, who can interpret this for you and explain what it means and what's next. So you're an advocate. The more you know, the more familiarized you are with your loved one's condition, the better off you can be as an advocate. If you've had to walk in cold and your family operates in maybe a method of secrecy and not fully disclosing what's going on, you don't really know what's going on with your dad's meds. You don't really know what your dad's diagnosis is. Maybe your father's been diagnosed with dementia and you don't know it. You know something's wrong, but you don't realize that he is on a memory drug. So when you get into the emergency room, you're at a huge disadvantage being able to advocate for him in a powerful way, in a way that might make a difference, versus someone who's in the dark saying, gee, I didn't know that, and this is all kind of hitting me new. So important for you to familiarize yourself with what's going on so that you can speak from a position of knowledge and essentially power. Asking questions. It's a really good thing to do when you don't know what's going on. Instead of assuming, ask a lot of questions. What about? Remember, the emergency department is a stressful environment for everyone, not just for you, for staff as well. You have no idea what's going on in the next room. And if you feel as though you're not getting attention, certainly go out to the desk and say, is it possible to see the nurse assigned to my mom, my husband, my child? I feel as though we need to touch base and see what's going on. If you're in the room with your loved one and something happens, of course, you open that curtain or you open that door and you just shout out, I need help in room 10. Immediately, emergency, I need help in here. Everyone is on the go. Everyone in the emergency room has on their virtual roller skates. They're wearing their nice, I'll date myself, Air Jordans. They're wearing their nice sneakers so that they can jump at a moment's notice, not just physically, but mentally and professionally and cognitively, to respond to whatever happens. They're first responders. That's what they do best. So if you are going to advocate, you ask a lot of questions, and then it's careful to listen. We can't remember everything that's told to us, especially when our adrenaline is pumping and we've been through something that's traumatic. Take notes. Ask them, do you have a clipboard and a pad of paper that I can use to take notes? We always, in our packets, we have little Aberdeen notebooks that we stick in just for that reason. So that if you're in the emergency department, you have a place to write down. Because right now, particularly during COVID, they're not letting the army of relatives into the emergency department that may have happened in the past. You'll have one person that's allowed to come in with you. Now, when COVID was first hitting us in the winter months, emergency departments were not letting anyone in except the patient. If we return to a model like that, this kind of information will be more important than ever, because you will not be allowed to be an advocate that's right by the bedside. You may be able to be in the waiting room. I remember even days when they weren't letting people in the hospital at all, and you were sitting in your car in a parking lot with your telephone waiting to FaceTime with somebody in the emergency department who could tell you what was going on. Those are scary times. Scary for you, scary for the patient. So the more you can be prepared ahead of time, the better outcome you will have. The outcome. That's really what this is all about. Knowing or having a clue about expectations. What is the emergency department going to do for you? And what are they not going to do for you? Remember, it's a portal. It's your entry place into medical care. It's not where you're going to stay. Now, I say that, but there are some times when there are no beds available. And so people are waylaid in the emergency department waiting for an open bed in another location in the hospital. If you are clearly a neurological patient or clearly an orthopedic patient, and they prefer to send you to those specialty units, and there is not a bed in those units, they may retain you in the emergency department until such time they can transfer you to the appropriate unit. Sometimes when the emergency department is bursting at the seams, they need that bed. So even if you are an orthopedic patient, you may end up on the neurological unit until they can transfer you to the appropriate place. That feels very disruptive. I've been in that situation, and it feels maddening, to be the loved one of someone who might be elderly, confused, in distress, in pain, and having them constantly be moved to different units. People really like consistency. What is the thing that I got asked probably the more than any other question in the hospital, other than when am I going home, is when are you working again? Are you working tomorrow? Because bonds are made. People are reaching out for a sense of comfort. And when they find that, they don't want to let that go. So it is very disruptive to find a unit where you feel heard, seen, valued, taken good care of, and all of a sudden need to move to another unit. But for you to understand the backstory about what's happening in the hospital might be helpful, so you can maybe go with the flow a little bit more than you otherwise might. Realistic expectations. We're not going to get every piece of information that we need in the emergency room visit. You may get a preliminary CAT scan. You may get a preliminary MRI. Your blood work may get run once or twice. You may get one chest x-ray. Whatever it is, however you are being diagnosed, you won't probably get the full workup until you're evaluated by more than the emergency room physician. The emergency room medical team has access to everyone in the hospital. The larger hospital you go to, the more likely that you're going to be able to see every specialist right there in the emergency department because they have them on staff. If you're in a community hospital, probably very different. There's not going to be a neurologist that's available or an orthopedist that's available 24/7. So sometimes it depends where you go. Another important point is hospital preference. And on our sheet, that's our first question, is hospital preference. Where is it that you would like to go if you have a choice? If you're in a life or death situation, something that's really medically needs emergent attention, you may not get that wish. You may not be able to go to a Boston hospital if you live on the North Shore. Ambulances are operating under physician orders. They don't just come up with these ideas on their own. They have a medical director that dictates what happens when they respond to someone calling out for their service, if that's 911 particularly. Let's use that for an example. So when you call 911, the ambulance arrives with the police, with the fire, that's how it works. And if the police and the fire are discharged and we realize, yes, we're going to put this person in the vehicle and take them to the emergency department, it all depends on the assessment of the EMTs or the ambulance personnel. Where do you belong? Do you have the luxury in time of going to the hospital that you prefer? See, we're all these networks, right? So if you live on the North Shore, You could be in the Leahy network, you could be in the Partners network. So we have the Beverly hospitals and their affiliates that are part of the Leahy system. We have Salem that's part of the Partner system in Mass General. And so if you really are comfortable being in your own network, you can always make that request. And it will be up to the people in the ambulance whether they feel it's medically appropriate for you to go the extra 10 minutes or the extra 20 minutes to get to your hospital of choice. So what's next? What's next after your emergency room visit? Well, that all depends on what they find. Is this a treat and go home? Hopefully, that would be great. And if not, what's next for you? Is it an admission into the hospital? Treatment, depending on what is found, what's going to have to happen? Will you be going straight home from there? Will you need to go to a rehab facility? It's hard to know, but ask a lot of questions and use that same notebook. Keep all your information together, because we're talked to, especially if you're in a Boston hospital, and let's say you have a cardiac issue and you're diabetic and you go in with pneumonia, you've got 4 medical services right there. You've got respiratory, you've got endocrinology, which is the care of diabetes, you've got your medicine, your primary, and I think I mentioned one more thing, maybe an orthopedist, but you've got 4 services that you're dealing with. You have a first year, you might have a medical student, you might have a resident, you might have a senior resident, you might have someone doing a fellowship. You could potentially have 5 practitioners from each of those services. They try to be very gentle and careful about not overwhelming you, but there will be a lot of people in and out of that room. So taking notes is incredibly important, so that whoever your advocate is, whoever your health proxy is, can try to keep track of this for you. There's nothing more difficult than when you're struggling with a medical situation to be trying to be your own scribe, writing your own shorthand notes. Who can remember what that said? You write down the word green. Who knows what that means? Maybe in your mind at the time, green meant go, and you were good for discharge, and now you look at that and you say to your daughter, well, it says green in my notebook. I have no idea what that meant. That's how my brain works. Maybe not yours, but it is important to keep good notes, stay current with the information, especially if you are the communicator for the rest of your family. I do know that this is true, that hospitals cannot be sharing information with 10 people at a time. In fact, because of the HIPAA, which is the Privacy Act law, they're not allowed to speak to anyone unless they have written authorization from the patient. That can take a form, many forms. It can be in the healthcare proxy document. It can be in a entirely separate document, which is what Aberdeen uses, which is a waiver of your HIPAA rights and identifying who the hospital personnel and who medical people can talk to and share information with. That doesn't mean that if that's me, it doesn't mean I'm a decision maker. It just means that I can be given medical information relevant to whatever individual we're discussing. So stay tuned to the end of this program. We're going to show you this the sheet that you can print, which is the program for today, outlining the things. You can take your notes, outlining the issues and the segments that we talked about, as well as your medical information sheet, your wallet card, which you can make your own on a little 3x5 card, your healthcare proxy, and your MOLST. These will all be downloadable, or there will be links to how you can find them and make your own little clever kit. Make sure it has your name and your date of birth. Allergies should go right on the front, and maybe your primary doctor's name and telephone number and your hospital of choice right on the front of your kit. If you have other questions, you can always check us out on the website, and there's a way to contact us right there on a tab on the website, and that is aberdeenathome.com, and that's Aberdeen, ABERDEEN @ home.com. So visit us there, aberdeenathome.com, online, lots of information there, and go to the tab that's indicated on the graphic, and you'll be able to pull up all this information. I hope this has been helpful in empowering you and educating you and giving you information that's powerful in terms of how to navigate an emergency room visit, which is honestly mysterious to many of us. Now that you hopefully have decoded some of that, you can be a better advocate for yourself or your loved one if it comes time to visit that emergency room, because in my experience, it's not if, it's when. Thanks for joining us. Great to be with you.